Welcome to the annual OSHA training course. What we want to start with is an outline, and we want to talk about the epidemiology and spread of disease, exposure control plan, hazard communication plan, and safety plan. The first part is going to involve the epidemiology and spread of disease, and this is a required topic. And simply, there's four ways in which we're going to have transmission of infectious diseases. That is by aerosol, and remember that aerosol are suspended particles in the air, spatter, which is visible droplet formation by directly contacting either saliva or blood or other contaminated materials, and a common vehicle, which would be a contaminated instrument tray or other item. So the first real part of our program would be the exposure control plan. Exposure control plan has got several parts to it, which you can see on the screen in front of you, including the rule itself, definitions, exposure determination, methods of compliance, personal protective equipment, housekeeping, hepatitis B, and post-exposure evaluation and follow-up. We want to just start by telling you about some of the changes that have occurred, and on the screen you can see that these are the changes. In 1992 is when the rule started. In January of 2000 we added hepatitis C exposure testing. Some changes occurred to do with needle sticks, illness and injury reporting, and finally, there was a related publication of the CDC infection control guidelines, which were published in December of 2003. The exposure control plan is the first part of the program and includes all these items that you see listed. And the thing about it is that we have to have in the office a written exposure control plan. And in there, it's going to explain everything there is as listed on this slide, and also has to be made available to the Assistant Secretary, that is an Assistant Secretary for Health, who is in fact the OSHA inspector for examination and copying. The first thing that we have to do after reading the rule and the definitions that are in the rule, we will do what's called an exposure determination. In there, we have to list all the job classifications where every employee in that classification has potential for exposure. For example, a dentist performing clinical duties or a hygienist performing clinical duties. The second category is job classifications wherein some employees are exposed, and that might be the administrative personnel of the dental office, wherein most of the people out front do not go back and get involved with any exposure-prone procedures, except that the office manager is a former hygienist. And when some of the personnel are ill, such as the hygienist or dental assistant, that administrative person undertakes tasks which could have exposure. Finally, we have to list all the tasks and procedures wherein there could be exposure, and these should be broad categories of tasks such as chairside dental assisting duties, chairside dental hygiene duties, dental laboratory duties. The first part of the compliance involves a general clause, and most of the parts of the rule begin with a similar clause. This one starts with the concept of universal precautions, which we have to, it's a philosophical concept that we maintain in order to comply with this rule. That concept states that we're going to consider all body fluids as potentially infectious and all exposure incidents as having the potential of spreading infection. The short story is that we basically treat all patients as if they are in fact infectious. And then some of the details involving this include engineering and work practice controls. And engineering control is something that you do that isolates the risk from the personnel, such as, for example, rubber dam, high-speed suction, and sharps container. There are not very many engineering controls in dentistry. However, there are many work practice controls. These are things that you do, but that don't isolate the risk like an engineering control, but that reduce the risk, and those are called work practice controls. Some of them that you can see here might be disposable towels, electric eye soap dispensers and water faucets, and various other things that we can see here in that slide. The important thing to remember is that if we adopt an engineering and or work practice control, we got to make sure that they actually do what they're supposed to do. That is, that we maintain them and replace them and keep them in proper working order. Also, in this section is the only section in the OSHA rule where it talks about hand washing, and the only time, according to OSHA, that we must wash our hands is after glove removal or the handling of personal protective equipment with our bare hands. Remember, too, that we must remove our personal protective equipment before leaving the work area and store it in a designated location. We also have in this section the issue to do with our needles and sharps. Now remember that while the rule says we should not recap needles, OSHA understands that in dentistry our local anesthetic needles can and should be recapped, as it is not safe to leave them in an unrecapped condition on the tray. However, we should use a one-handed scoop or a device, a protective device, if recapping with two hands. Also, disposable syringes, such as, for example, endodontic syringes for irrigating, those, if they are considered a sharp, the entire needle and syringe body needs to be placed in the sharps container. You're also reminded by the OSHA rule that we shouldn't eat or apply cosmetics in operatories and in other places where we have contaminated materials, and that we if we are in, for example, an oral surgery facility, a hospital facility where we're storing blood and other tissues, then we should not store food in locations, in those same locations. Finally, we should remember that splashing, spraying causes the spread of disease, as you can see in this picture, using fluorescent paint. And that's probably on rare occasions, but mouth pipetting is no longer permitted, and mechanical pipettes are now the standard. The next section after the engineering and work practice controls involve our personal protective equipment, and this is abbreviated as PPE, such as, for example, our gloves, our masks, and our gowns. Here you can see a photo of some of the personal protective equipment, including the face shield, as well as mask and protective eyewear. Normally, we would select either a face shield or the mask and protective eyewear. Remember, too, that the employer must provide the personal protective equipment. The employer is required to make sure that the employees use it and use it properly, supplying any types of repairs, and also, if there's allergy problems, that the employer must supply hypoallergenic materials. Also remember that we cannot take these outer garments home for cleaning and laundering. It must be supplied by the employer. However, laundry can be done in the dental office or be transported to the cleaners by an employee if that's part of their exposure-prone procedures. Also, remember that utility gloves and thermal protectant gloves are very useful protectant devices that are needed from time to time in the dental office. The big issue in dentistry is the outer garment, as many people like to select their own uniform, their own clothing, relative to their body build, style, colors, etc. The most important way to be able to do this is that the outer garment be a gown, and that be supplied by the employer, and that those gowns be selected by the employees as the outer garment when exposure-prone procedures are to be carried out. On the other hand, the facility can supply uniforms, gowns, etc., and the employee would then change into their street clothing upon leaving the facility for the day, or even to leave for lunch, go to the bank, and other duties. We cannot be wearing those outer garments beyond the confines of the dental office. The next section is housekeeping, and this involves everything except personnel, such as instruments, the floors, and cabinets. You'll notice in this photograph that the person carrying out infection control procedures is not wearing gloves. This is an older advertisement where we didn't yet understand the importance of personal protective equipment used in cleanup procedures, as well as when patients are present. Also, the office must have a written schedule as to when these procedures are done and at what time of the day, and the schedule will depend on the location. For example, the floors are different from countertops, the type of surface to be cleaned, and the type of soil, for example, blood versus simple dirt, and the tasks that are being performed. So those 4 things determine the schedule that is drawn up for those duties. You can see here that the schedule for cleaning and disinfection might have daily, weekly, and monthly versions, depending on the nature of cleaning required based on those 4 previous points. Also, within this area, we've got regulated medical waste, personal protective equipment, and laundry, which we want to address. If we talk about cleaning and disinfecting, we've got 2 choices. We can either disinfect or cover work surfaces. So, as far as our scheduling goes, we're going to clean up by spray, wipe, spray, wipe, and leaving the material for a short period of time, the disinfectant for a short period of time, and then wiping. And this is done perhaps, for example, between patients or at the end of the day. In here, you're looking at a chair that is used for the taking of dental x-rays. Also, other than disinfecting with a chemical solution, we can use barrier or protective coverings. And as you can see in the photograph, we have barrier protected electronic controls for the x-ray machine, as well as the countertop for the contaminated x-ray films and positioning instruments. You notice that many types of materials can be used, such as plastic wrap, aluminum foil, etc. One point that OSHA wants us to understand very carefully is that the very first thing we do with contaminated reusable items such as instruments is that they immediately be disinfected or decontaminated in this holding solution type situation before we do anything else. This is to minimize the spread of infection to those whose duty it is to clean up and disinfect the instruments. As you recall, in this section we have regulated waste, and sharps are pretty well got to be, non-sharps are pretty well got to be placed into either a red bag, an orange bag, or a bag that has the biohazard label. Remember that regulated non-sharp waste only consists of items that can release blood or saliva upon being compressed. That means that dirty gloves, patient napkins, masks, etc. do not constitute regulated non-sharp waste, but rather, if you had blood-soaked gauze or sponges, then which when you compress it releases a fluid, that is what is considered regulated non-sharp waste. Sharps, on the other hand, have to be placed in a sharps container, and these must meet all of the criteria, which includes the fact that OSHA, as well as the new CDC infection control regulations require that they be in the immediate vicinity of use. And if we make any changes in that, we must have that in our OSHA compliance manual, such as we will have the sharps container in the cleanup area. One issue that's very important as far as OSHA goes is hepatitis B, which we must offer the vaccine within 10 days of employment. The only exceptions are as follows. A, that the employee can show that they've been previously vaccinated. Secondly, that antibody testing proves immunization, such as, for example, they had hepatitis and recovered. And thirdly, that the employee declines. And then it's important that the employee signs a declination statement. It is a very specific statement that is reproduced in the rule itself. Also, booster doses are provided according to the current health guidelines, and that antibody testing is made available. If the employee proves to be antibody positive, then the employer does not need to offer the vaccine. Now, if an employee has an exposure incident, such as poking themselves with a contaminated sharp instrument, then a post-exposure evaluation and follow-up must be offered. And when that happens, there's certain things that kick in, basically consisting of how did it happen. We're going to have hepatitis B, hepatitis C, and HIV testing of both the employee and any source patient or patients, and all of that is to be done by a properly licensed physician and or laboratory facility. Also, it's encouraged, the rule strongly encourages that if there is any possibility that this patient, if we go under our general clause, then also we would initiate within a few hours a treatment which helps to prophylax against becoming HIV positive, which is anti-HIV drugs that are given as soon as possible to help prevent becoming HIV positive. In addition, more recently we have had to include hepatitis C testing, and that is now recommended after an exposure incident. Also, post-exposure prophylaxis does not prevent the development of hepatitis C, which is with an interferon drug called interferon PEG-29. However, it does promote the formation of an antibody, thus preventing the prolonged carrier period of 10 to 20 years that normally occurs with hepatitis C infection. Finally, record keeping. As with all government standards, there is a small degree of record keeping that is needed, and it's one of them, the most important one, is the medical record, which, as you can see, must be kept for a period of 30 years or transferred to the next employer, and upon retirement of the practitioner, that they be offered to OSHA for further examination. Remember that records to do with sharps, injuries, and work-related illness are no longer required in dentistry. The second part of the OSHA program involves hazard communication, and you have a hazard communication plan to comply with that. You can see various parts of it, including the standard, labels, both biohazard and secondary, the hazardous chemicals list, MSD sheet. There's a new hazard-related personal protective equipment standard, came out in 1994, chemical spills, eyewash station, equipment-related hazards, and employee hazard communication training program. These are the elements of the hazard communications part of the OSHA rule. As you can see, the biohazard label is a pretty well recognized symbol, and there on the screen you can see a list of some of the places it can be, the label should be placed. Should be placed where on containers with items that are in a temporary storage state. They should not be placed on trays during the time that, for example, instruments are being used. As you can see from this list, for example, instrument soaking container, ultrasonic cleaner, lab trays. They are temporary storage areas containing contaminated materials. The warning labels, as you can see, are the biohazard label. And remember that red or orange colors, as you see in this photograph, the orange color can be substituted for the biohazard label. Many times we see a combination of red or orange color along with the biohazard label consisting of 3 circles in a triangle with a central circle. Secondary labels are different from biohazard labels. And you can see in the photograph the larger white SUV container, which this is a quaternary ammonium material, is a secondary container. The primary container contains the concentrate, which is then diluted in that secondary container. Now, the secondary container contains material which must have the same labeling as the primary container. Therefore, if the container is not supplied with a secondary label, the practitioner must then add this secondary label with, for example, the name of the contents, precautions in case of spills or in case of exposure to the eyes, etc. In this hazard communication, there is a rule that involves the use of personal protective equipment. But the personal protective equipment is not against a biohazard. It's more against physical hazards, such as, for example, sparks or chemical, strong chemicals such as, for example, acids, which could burn. You notice that on this list here, then, we must do a hazard assessment. We must supply proper personal protective equipment related to this type of hazard, and the personal protective equipment has to be maintained and supplied in a manner similar to the bloodborne pathogen part. But as I was mentioning, this is for physical hazards. Remember too that the employees must eventually be checked to see that they have knowledge, and 2 certificates are required. One is a certificate of hazard assessment, and secondly a certificate stating hazard training has occurred. Part of hazard communications is dealing with chemical spills, and a spill kit contains material which will absorb a liquid spill, neutralize noxious odors, and be able to contain it into, for example, a plastic garbage bag, and then tie it off so that the noxious odors can't escape and harm the occupants of the facility. Also, then, in this part, there's the disposal of hazardous chemicals. However, in dental offices, most chemicals can be disposed in a sanitary sewerage system. The eye wash station is also part of hazard communication. As you can see in the photograph, an eye wash station is for rinsing eyes when they are exposed to a noxious material. And there are standards. It must be within 25 feet or 10 seconds of anywhere in the dental office. It must be able to spray both eyes, and the pressure should be such that it cannot damage the eyes. In other words, there should be a pressure control valve, and that the MSD sheets be placed in the near vicinity so that appropriate rinsing instructions can be accessed. Other equipment-related hazards involve compressed gas cylinders, which may contain nitrous nitrous oxide or nitrogen and separate oxygen containers. The LP fuel cylinders are usually consist of propane. We don't have very many flammable or combustible liquids in the dental office, perhaps monomer. And then many electrical things are listed in order to ensure that there is no electrocution of employees or short-circuiting due to various standards that are in the community for the licensing of the facility. The last thing that we have to do is make sure that we train employees, as you are doing today, in hazard communication, speaking about these various items. The final part of the OSHA program involves safety. The safety plan is probably the briefest section of the three and involves general safety, medical safety, needle safety, and fire safety. In our photograph, you can see many of the items. You see some emergency lighting, you can see a fire extinguisher, and the first aid kit, which are going to be addressed in various aspects of this. On the employee bulletin board, which is a special set part of it, remember that that orange poster that you see the employees looking at is a Form 2203. Every dental office must display this form, and it describes OSHA employees' rights under OSHA. Other things that can be on that board are listed there, such as emergency phone numbers, notice of information location, such as where are the MSD sheets, and so on. Also, signs, specific signs being posted. We must always have proper posting of exit signs that are properly lit in on its own independent power supply. They must be either red or green, and whether there's accessory light or not is not important as long as the sign is there. Notice also that you see some items listed on the slide, such as room capacities, floor loading limits, etc., and that will change from one community to the next according to local regulations. The first aid kit is different from the emergency kit. The first aid kit involves band-aids, disinfectants, etc. Make sure that the office does at least 2 or 3 times a year a review of the contents, and that on a card inside the first aid kit that there be evidence that the kit was checked once in a while to make sure that proper contents, the proper supply of band-aids, etc. is present. Other parts of this involve the eye wash station, which has already been mentioned, protective belts for lifting heavy objects, which does not occur very much in dental, and the pocket CPR mask, which must be on hand so that we don't have to have mouth-to-mouth contact when resuscitating patients. Fire safety includes the list that you see in front of you there, some of which include fire alarming testing, automatic sprinkler system issues, the placement of fire extinguishers in a dental office, and other things that you see there, such as exit ramps. So that concludes our program, which was produced by Robert Langley of San Antonio, Texas, and Robert Cederberg from Phoenix, Arizona.